we'll just get right to it. Hey, Libby, thanks
It's so
for
good
coming.
to see you.
Our second hug, and always good to see you. Always good to get those beautiful hugs from you. So thank you.
You also.
Yeah. All right. So thank you for being here, being willing to have this candid conversation. Conversation about medical aid in dying, or the stance that I would take is physician-assisted suicide. It's just beautiful when we can, really on any topic, have real open conversations, respectful, despite disagreeing and sometimes strongly disagreeing. So.
And I think we've always had that ability to have that discourse, and I wish everybody would be able to do that. I don't expect to change your mind, nor do you expect to change mine, but I think we expect to learn from one another and to teach our own stances to others who might be watching us.
Yeah, because there's not too much conversation. I see a lot of things in the media just supporting good stories and the legalization in new places or furthering of the laws, developing of the laws. But we don't really hear too much of opposition, and we also don't see too much. You do hear some? Okay, good.
I do.
Yeah, but there's definitely not too much conversation about it.
That
so.
there isn't the back and forth that there needs.
Yeah.
There needs to be on any difficult topic.
Yeah. So thanks for being with me.
Good, of course.
Yeah. So how about you give a little introduction to how the law came about in 2021? Maybe a little story, background leading up to it, starting like 2019 in your involvement, and go from there.
Absolutely. So maybe introduce ourselves. Do you want to tell who you are?
Yeah, sure. Okay. My name is Miles. I'm the director of the Nora Home in downtown Albuquerque. I'm really new to end-of-life care. I'm an RN. I was a nurse for 11 years within the VA system until I launched this home when amazing people like Libby came together to make it possible, where we're able to provide compassionate end-of-life care. Really second to none in our community. It's just thanks to people like Libby and others who make it possible.
Many others.
So,
yeah.
Yeah.
And you've done an amazing, unbelievable job, Miles. And my connection with end-of-life care, I'm a certified hospice and palliative care nurse, and have been certified as a certified in hospice and palliative care administrator, though less my preference. Clinical care is much more my preference, and volunteering.
It definitely shines here.
And I've got, I'm a registered nurse, and I have additional graduate certificate, postmaster certificate in applied thanatology, which is the study of death, dying, and mourning. And I've been practicing hospice and palliative care. I've been a nurse about 42 years. I've been practicing hospice and palliative care 21 years now, and it's really become a part of who I am. And while we disagree, we both have different cultural and religious backgrounds.
Right.
And while we disagree, we have the absolute same values and morals around giving people the opportunity for a dignified end-of-life experience. Our definitions just differ a little bit.
Yeah, in the one area primarily, but yeah, there's nothing like supporting somebody in that once-in-a-lifetime opportunity and being there during those last breaths.
It's amazing.
Yeah, the silence, the wonder of it. So
yeah, it sounds trite, but I always say we get more than we give, and we really do. It's a privilege to be in people's lives at this time, regardless of how people get to this time. So the law was initiated. It was first introduced, it must be 25, maybe more years ago now. And it didn't pass. And then about 10 years ago, the law was passed and it was overturned. It was appealed and overturned. And then 2 tries, and we were able to pass the law, and I was involved in the writing, the implementing, and the organization of putting the law and putting everything in practice, working with Elizabeth Whitefield, whom our law in New Mexico is named after.
Yeah,
and so it's very fortunate. So Elizabeth Whitefield was a very respected and just fair, objective judge, and she had, I've never known in all my years of nursing anybody who had as many kinds of cancer as Elizabeth did. And she had many and outlived the odds. Her final cancer was throat cancer. She had a trach, and she also had some metastasis in the rest of her body, and she was suffering mightily despite the best hospice care, despite the best care that was possible. And so we can't make every death a good death, no matter how good the care is. And we can't make everybody comfortable, no matter what. And she was involved in introducing the law and very involved in writing the law. And unfortunately, the law did not pass in time for her to utilize it, and she had a severely agonizing, horrific death. And so, despite the best hospice care around, and so we named a law after her.
Yeah. So hospice care, for those maybe who are watching this and don't know, is a comfort. It's basically it's an option for people that have Medicare, Medicaid, and they're able to access, I believe, up to $33,000 throughout their lifetime with hospice measures. And to access them, they basically say, I realize that I'm coming to the end. I've got 6 months or less to live, and I just want to be as comfortable as possible. I don't want to seek the curative. I just want to be comfortable. And it sounds like she really struggled with getting that. Can you maybe, from all of your experience, talk about conscious sedation or palliative sedation?
Sure, absolutely. So what we have available to us in our state, fortunately, is a full range of options. We don't think anyone should or should not use aid in dying, should or should not use hospice. This is a very individual decision. We think people should have the right to choose among those options. And they are from having the highest level of care, which is having a ventilator, a respirator, and being kept alive by machines and tubes even when brain dead. And we do have the right to make that decision. And then the next level is palliative care. And palliative, as opposed to hospice, palliative care is for anyone with a life-limiting illness. So it's comfort care, and you can still seek curative treatment.
Right.
So it's very focused on symptoms and quality of life. Hospice, as you said, focused on quality of life, but we are foregoing active treatment for our terminal illness.
Right.
And next in that continuum is palliative sedation, and that is legal. Next is, as V said, voluntary stoppage of eating and drinking, and everyone has the right to do that.
And that's legal anywhere, because it's
legal
a matter
anywhere.
of somebody just making that choice.
It is
I'm
making
going to
the
stop eating
choice.
and drinking, and with the intention of hastening their dying, hastening their death.
And then following that is palliative sedation. And that is where we administer a large amount of medications, but we stop when the symptoms are managed. So if somebody is having severe psychosis and anxiety and pain, when they fall asleep or they appear comfortable, then we stop. And so the intent is absolutely not to terminate the person's life.
Right.
It is to bring about comfort. It is possible that people will, not with the intent of them dying, but will die as a result. And so it requires chaplaincy and social work and other disciplines and physicians consulting with one another with that individual to make sure that they understand the consequences of their utilizing this, and that may unintentionally result in death. So that's the next level, and then of course the next level is medical aid in dying or death with dignity. Which we both believe that we believe in death with dignity.
Yeah, we do. But
We
it's
just disagree
interesting
on
that
the
it's talked
definition.
like that. Yeah. I was just pondering that. this week because one of the agencies that are promoting medical aid in dying, I believe Compassionate Choices, it was called the Hemlock Society beforehand, in recognition of that post that I mentioned today, or I guess it's kind of stirred things up a little bit of me saying that medical aid in dying is really an overdose, and I guess we could say it's a type of poisoning. But right there, just a little backtrack is, first off, thank you for walking us through, because that's really clear, and I agree, and I would say those that are maybe educated on the topic would agree that all of those measures, supports that are available, from curative when people want it, all the way up to palliative sedation, are all.
And I didn't mention the choice not to be intubated, not to have
That's right.
A ventilator, or to do not resuscitated, not be resuscitated when they die.
Yes, so people can make that choice as well. And for those of you that haven't made an advance directive, we definitely encourage that. And I think both of us would say 5 Wishes is a great place to start.
Yes, and you can let us know via Nora if you need information, and I'll give, closer to the end, I'll give some organizations, the Conversation Project, 5 Wishes, and some others with phone numbers and email addresses, so that websites.
Okay. Now, the reason that the disagreement comes up is primarily because of the change of intent, where up until palliative sedation, it's always intended towards comfort, but then once it gets to medical aid in dying, the end result and the aim is death itself.
Mm-hmm. So it is, in fact, the intent is comfort. And so if we talk about, the main thing that I think is important here is the person who is engaging in medical aid in dying is the individual, him or herself. And so we have the Patient Self-Determination Act from 1995, and then our New Mexico law, the Universal Healthcare Decisions Act. And within those, we have the right to make decisions about our lives and our deaths. And so, that said, we are not telling someone else that they should die. We are not killing someone else. Murder is illegal and will always be illegal in the United States of America. Mm-hmm. And people are making their own decisions about the end of life. When there are many safeguards, of course, and you mentioned you must be an adult, 18 years or older. You must be decisionally capable to make healthcare decisions. And if there's any question about that, the law requires a mental health consultation, and that follows the same decisional capacity evaluation as anybody might have in an illness or any kind of cognitive disorder. Are they able to understand the decision they're making, the outcome, and all the things that lead up to that? Mm-hmm. And so that is the same decisional capacity.
Mm-hmm. And maybe that's actually a good place to start the conversation, is about that sense of autonomy and what that means and what those laws mean, and where I think a choice to end one's own life is not an autonomous decision, because we'll just jump right into it. So I think that there's different factors that are going on in people's lives that are pressuring them psychologically, physically, and in other ways, where they feel like it's the only option or the best option. Some of those fears could be what hospice and you and I have been working hard, me in the last year, but you throughout your life, which is trying to help people not be afraid of dying, helping them to be open and have conversations about death and dying. What I see is choosing medical aid in dying can be, for some people choosing it, a choice to avoid what their death might look like in order to not face that fear and not work through that fear.
So it is the responsibility, and I have sat with people who have utilized aid in dying, and I've had many conversations with many providers who have written the prescriptions and worked alongside them. And it is the responsibility, and it is the intent of the law, that every provider must tell the entire spectrum of choices. And within that is also, when they're describing aid in dying, to assess, and again with the chaplain and the social worker and the team, what is driving the person to that. I will say that Enora is for those who are unhoused, unsheltered, don't have any loved ones around, all of those in need is an option, or just lack of finances.
Supports, where they need community to support maybe an already existing community.
Exactly.
But then also for those who have none.
And so I want to really stress that I believe that that is a great option. It's an unparalleled option that I've not seen anywhere. I don't know of anywhere in the United States or elsewhere. And so that is a choice, but it is fabulous that there is that choice, but it is not a choice for everyone.
And I think you hinted at it, but I want it to come out straight and just to make sure that it's communicated. Are you saying that it's a hospice provider that can write that prescription, or...
Okay, so that goes a little bit back to the law. Okay.
Yeah, can it be a different provider?
So it can be. Typically, people are on hospice, and you must have a 6-month prognosis. I didn't quite get through the safeguards, but you must have a 6-month prognosis, and that's the same as the criteria for hospice care. And so most people are on hospice. And so typically it is a hospice provider. No provider is obligated or forced in any way to provide that.
Right.
And they may not be. It's very, very clear in the law.
One little clarification about that. Are providers that don't support it required by law to give the option?
Yes.
So this, even though believing that it's suicide, believing that it's bad, they're forced by the law to give the option.
They are, or to refer to either another organization or another provider who is willing to tell the entire law. We don't hide. We don't hide our laws in the United States. So yes, we have to tell the entire law. Maybe I don't believe. I'm not saying I don't, but if I'm brain dead, I don't believe in taking up the resources and, putting my family through the agony, or any agony I might have that I can't show by being on a respirator, ventilator, and machines. But I certainly have the obligation to tell people that that is an option for them. We aren't recommending any option. We have to tell that.
But this is just, it's important to realize and to recognize that the person who wants medical aid in dying can keep looking until they find a provider that's willing to offer it to them.
And they must be referred, in fact. So if a hospice doesn't provide it, it's in fact explicit in the law that they must give that information when somebody, in their admission materials, that they do not provide aid in dying.
Right.
And you can still use that hospice just like you can stay here, but you can't utilize it here. So many hospices will refer to another hospice, which is one choice. Or you can keep them on the hospice but not prescribe.
What about those providers, and I would feel like if I was able to write the prescription, where they feel that that knowing that they can't offer it, but being forced to refer, where they feel guilt and partly responsible because they're connecting somebody with something that they think is not actually good for that person, and then vice versa. It's interesting that the pressure is on those with a moral stance, and those who strongly believe in assisted suicide, the pressure is off of them because they're simply waiting for the resource or to be called or contacted, where there's this necessary weight that's put on those that don't believe in it to refer to the people that will write the prescription.
And so we kind of didn't finish that. There are other people outside of hospices, they're not hospice providers, to answer your question, that are experts in end-of-life care and do provide the service, can write the prescriptions.
Tell me about that. So non-medical?
No.
Oh, okay.
No. Physician, providers.
Okay. So they are physicians.
So
not
an
nurse
MD, a DO,
practitioners,
a nurse practitioner,
okay.
PA.
They can as well.
Also. If it's a nurse practitioner or PA, there needs to be another signature. There needs to be actually two people assessing. Only one if you're on hospice, because the hospice provider is one. And then you need another provider to agree to it. So
there's a little loophole in that though, because if the provider is referring someone to hospice, but not knowing it's for medical aid in dying, you're saying that it's assumed that first provider essentially is writing off that they are eligible for medical aid in dying, even though they didn't discuss
absolutely
it?
Not.
Just
no,
through...
you refer, and then the onus is still on the prescriber to show that.
Right.
If someone discusses that they feel they want it, then you refer them to a hospice that does, in order to have the discussion.
Yeah.
No, there's certainly no promise that you're eligible.
Well, let's say it's a primary care provider who's just referring someone to hospice. Then you're saying that person referring counts as one of the signatures? Counts as one of the verifiers?
No,
okay,
absolutely
so it has
does
to
not.
be. Okay,
Absolutely does not.
Describe that nuance
It's a part of the system that two providers must knowingly understand and meet the Medicare criteria for a 6-month prognosis, and those are very clearly written.
So they have to agree on that they have a 6-month prognosis. What else do they have to agree on?
They're 18, they're an adult, whatever is adulthood in the given state. Some states have a residency clause. Our state does have a residency clause, but it's left to the provider to determine that there's a good faith plan for that person to live the rest of their lives in New Mexico. You can't just call a friend and go, can I come over for 8 and 9 today? If someone moves in with their family or something like that for their end of life care, then that
as long as basically
preferred.
Okay, so as long as they basically can show that they're going to end their life here instead of another state, then they can get it. But that's pretty much, that's what residency means, is that they're going to die here.
Yeah, well, yes. Okay. Well, all of us, so most of us are.
Yeah, but in New Mexico in particular for
That's
this
right.
law.
And there are several states that do not have, I think 2 or 3 states that don't have residency clauses.
Okay.
So an adult, decisionally capable, we talked about.
But these things, so the law requires it, but you're also saying both providers have to agree on all of these things so far. Okay.
Yes, and if either of those providers does not agree, for example, on mental health, either a mental health diagnosis or developmental delay or disability or some cognitive disorder, then if either one, then they must refer to a mental health provider.
Linking this to medical aid in dying, though, do both providers have to do that behavioral health assessment, are you saying?
No, they're sent to a mental health professional.
Okay.
No, absolutely not. They're sent to those professionals who do the assessments, who are experienced in their practice with decisional capability, the same as they would for if somebody is able to accept or decline, to sign a DNR, for example. Decisional capacity, decide if you want to forego surgery or have surgery, transplant, whatever it might be.
Okay. I'm kind of honing in on it just to make sure that I'm clear. So here's a scenario. Okay. Let's say a primary care provider is doing an assessment and they think that there's that prognosis and it's an adult and they've been caring for this person, they know them, and they refer them to hospice. once that person gets into hospice, so they're now discontinuing their primary care provider, correct?
Not always. You
Not
have
always,
a right under the hospice benefit to keep, if your provider will keep you and feels competent doing end-of-life care, you always have a right to keep your own healthcare provider.
Okay. But if they want to go to hospice,
Even
they
if
could
they're
have
on
both at the
hospice.
same time?
You can have
Both
hospice and
providers.
your attending physician, you still have a medical director
Sure.
within the hospice, but your attending physician may be your own primary care physician if they are willing to keep you and feel experienced and competent enough to do end-of-life care. So absolutely.
Okay, that's beautiful.
Yeah,
to know.
so you can, if I'm in the middle of the night on call for hospice, I'm going to call Dr. Smith, the PCP in the community,
Right.
if the person has accepted that. Now, does that person answer the phone all the time? No.
Yeah.
But we're always going to consult them
Okay.
first.
So what we've seen in this home is that they always stop their primary care, and maybe that is.
They do
more-
not always, it's just a coincidence that
It's
that
just
has happened.
happens, yeah.
Every person on hospice, according to the
They're able
medical
to.
care,
Yeah.
Medicare conditions of participation, has a right to keep his or her own primary. And you may not even know that they've kept their own primary. But if every single person who's come here so far has, it's a coincidence, and because the majority of people, because they're experienced and they're available 24/7, and
Right.
those
So they just
kinds of
defer to the
things.
hospice.
And yes,
But if they wanted, they could involve their primary care provider.
absolutely,
Okay.
absolutely.
For those people, like going back to the scenario, for somebody who chooses to go to hospice, or the physician determines they're eligible for hospice, refers them to a hospice.
Okay, so we have a mistake.
Okay,
That
clarify.
physician referring to hospice isn't making that decision. They're just referring them. A referring physician doesn't prescribe surgery when they send him to the surgery.
Right, exactly. Yeah,
You
that's
get
what
to the
I'm saying.
hospice,
Yeah.
and the
then hospice will
hospice
determine.
itself, and it's very closely monitored, because there was a huge misunderstanding a number of years ago, and there was abuse many years ago, and it happened very seldom, but because that happened, it's very, very closely monitored. So the hospice and the hospice medical director has to agree, even if they keep their own attending, has to determine that there's a 6-month prognosis. And so according to Medicare criteria, not the referring, the hospice medical director, and the onus is on them.
So it's more like that primary care provider thinks that they meet the criteria, but is sending them to the professional to make that final.
Exactly. Your gallbladder, you've got gallstones in the ER, and I send you to the surgeon. I don't know that you're going to need surgery. Maybe, there's another treatment. I'm sending you to that expert for that care and that discipline.
This could happen in the hospital too. Somebody's hospitalized, they find out they're not going to get better, then that referral can happen inpatient in the ER, wherever they are, and then they get connected to hospice.
They do, and there are many, many models, and we have many in New Mexico, and there's hospital hospice, there's a hospice inpatient unit, which is not residential, that's for unmanageable symptoms, and same with hospital hospice, and then there's home hospice, and then there's residential hospice, which we are, but we don't provide the hospice. The hospices provide that for our individuals.
And that's a good
to make
distinction.
that clear. Yeah.
So in this scenario, whether it's the primary care provider or the hospital refers them to hospice, they get into hospice. Let's say that hospice provider is willing to write the MAID prescription. What else is required at that point?
Well,
Of the provider.
we've already determined that they're, and two providers have to say that they meet the 6-month criteria. They're an
So
adult,
those
they're
things.
decisionally capable, all of those.
But when does that second provider get involved?
At the
Does
time, and there's
hospice contact
paperwork.
a second provider?
Yes, and sometimes it's the second person is a nurse practitioner or a PA.
Okay.
If it's someone who's not on hospice, then the provider in the community that's providing the service has to have another, has to have an opinion. They're always, two people always have to verify their prognosis and so on.
So it could be two
Providers.
people within the same hospice, two doctors, or a doctor and a PA, doctor
It
and
could
a
be.
nurse practitioner in the same hospice.
And
that
I
can
will tell you
verify
that
each other.
hospices do not open hospices and practice hospice solely in order to do medical aid.
Of course, of course.
They are hired to follow that right of autonomy and meet the patient where they are. I don't say I only take care. I will only give Jewish people here
Yeah.
or I wouldn't have very many people here.
Right. Yeah, we have to encourage.
And so it is not. We have. Yes, I better.
Yeah.
And so the same is, and they don't go out searching for people. And it's never. I've never seen it taken lightly. If you want to finish this line of questioning,
Yeah,
then I want to ask you about your post today about overdose.
Okay, perfect. Where I'm going with this is trying to see how much weight is on the providers. We know that our healthcare system is already overburdened. We know that medical errors is a third leading cause of death in the U.S. And providers regularly will say that they don't have enough time with their patients. Now I know hospice is a little different. That's why I wanted to get into who's the one making the decision. Because if it was a primary care provider, they're only seeing the person
the
for 15.
individual, Miles, the individual is making their decision.
Right. But it's the medical provider which only has, 15 to 20 minute visits with their primary care patient who could be making these assessments.
They're not deciding whether or not they even are on hospice, let alone
Right.
They're
They're
referring to the
determining.
end of life experts because this person wants to be comfortable.
Mm-hmm.
They're not making a decision about, well, they will know if the person wants to be, on a ventilator and they have no brain activity and their otherwise bodies aren't functioning. They know that they won't refer to hospice because they're smart enough and know enough, even though we don't provide enough palliative education in medical schools. They know that to refer to a provider when you want that doesn't make any sense. Although sometimes it happens. That's fine. They make no decisions about whether the person comes on hospice and what path that they choose.
Yeah, so it's primarily
So it's absolutely not on primary who refers to hospice.
It is the thing that I'll point out here is that's a lot of weight to put on a provider with this new twist in healthcare, because all the way up until what I call assisted suicide, physician-assisted suicide, it's always been that we're looking at cure, do no harm. It's actually an oath.
It's only making it legal so that it can be done safely and with dignity, because our responsibility as hospice providers is to give people the kind of dignified death that they choose based on those autonomy laws.
So now a provider without without a behavioral health certification, degree, background required, they have this on their shoulders to determine if somebody is able to make the decision.
Yes. As they do for anything. Can I need a big surgery and I have dementia. That's that same responsibility to, if they don't think that they're decisional, as we call it, to sign the consent, it's that same responsibility to have that decisional capacity determined.
But everything else, including those examples you just gave, are about supporting life, are about providing care, treatment, options to sustain quality of life. But now,
mechanically, what about mechanically putting someone on a machine? That's not. Is that life if there's no life in the brain? I mean.
Well, like you said, that's an autonomous decision that people
can
make.
It is.
Yeah, and it actually. I'm so glad you brought that up, because there's many people who are told that they were vegetables, which is a really disrespectful and ableist term to call.
It is, I agree.
So there's a lot of people who are deemed living an unworthy life, like you were kind of hinting at, like this isn't a good quality of life, but who were totally present, were able to communicate, and became authors.
And were also able to make that decision with the understanding that, and when we sign our DNR, that we could be in a coma for 20 years and suddenly stand up and walk away. It's happened.
Or we could be in a coma for 20 years and be totally present and aware and write books and communicate our hearts and receive love.
Typically when somebody doesn't have brain capacity, they aren't doing that. But yes.
There are stories.
But yes, there are stories of people who do have brain capacity.
Exactly. Who were told, who were deemed that they didn't by medical providers.
Yeah.
Yeah.
And that's fine, because nobody's making that decision for them.
Mm-hmm.
The individual has to be fully informed and fully able to give informed consent, like for anything else, in order to do this. So if I suddenly get in an accident and I'm in a coma, Miles, no one can decide for me. My husband can't say, oh, I know she believed in, which doesn't make any sense, because we believe in just the right for the full spectrum. But she believed in medical aid in dying, so I'm going to have her do that if I'm in a coma. That's not happening.
Well,
you have to
unfortunately,
be
that did happen with Terry Schiavo, where all the way up to the end, including the husband, was saying this was her choice. She wanted this, and then all of a sudden he changed it. So he did get to change what she had originally communicated.
But we don't get to make those decisions.
Well, that husband was able to. And the provider.
That's discontinuing somebody else. That's a whole different topic.
Well, we were talking about like the vegetable people that aren't able. You said
for them, then yes, we go back to our advance directives.
Okay.
But if I want to use medical aid in dying, I can't be in a coma.
Mm-hmm.
I have to make that decision myself. Now, I can't make it in advance.
Mm-hmm.
I have to only make it when I have that 6-month prognosis and meet those. So I can't just say, oh yeah, when I die, if I have pain, I want to do medical aid in dying, so put it in my advance directive. Mm-hmm. That is not how it works. You have to be decisional at the time, not only at the time that you make the decision, and then there's a 48-hour waiting period, which can be increased in the instance of severe intractable suffering, and but typically it's our 48-hour waiting period, and during that time you have to continue to be decisionally capable. And at the time you ingest, and I have been at ingestions, and the law is followed, that they're asked again if this is what they want to do. They're asked again if they understand what the outcome is. So even at the time, you can't just lose consciousness in that 48 hours and use it. In fact, that's the problem in some states, that the waiting period is too long, and they lose consciousness and they suffer. But you have to be at the time. Does that make sense?
Or maybe they don't suffer, but the assumption is maybe they have some suffering. But hopefully, like you said, if hospice is
well, suffering is subjective. And so suffering is, whether it's emotional suffering, physical suffering, whatever it might be, we don't decide for others what their suffering is.
No,
that is not our right.
So, absolutely not. But in every other circumstance, we find ways to support people who are suffering, to care for them, and to journey with them, and not offer them a way to avoid it, a way to escape it, but a way to get through it.
Right. And we give the option, but that option isn't the choice of everyone, isn't the option of everyone. Mm-hmm. Not everyone wants to come. I mean, I'd want to come here, but this is the best care I've ever seen. But not everyone wants to leave their home and come somewhere else. Some people choose to die in their own homes, with their family around them, in their beds, with their animals. And so not everyone wants to have this option. It's a fabulous option. Don't misunderstand me. But it's not for everyone.
Right. No, and I know that. I mean, it's beautiful when people do have enough support so that they can have this experience in their homes. Mm-hmm. But it's a beautiful
with or without aid and dying. Yes.
Yeah.
Correct.
Well, in this home we don't do aid and dying. But yeah. So going back, a provider, that's a lot of weight on them to do a proper assessment and to make these types of determinations and to be the person that is the gateway to either getting medical aid in dying or not. And we already know they have to be somebody that believes in providing it and prescribing it.
And people's right to have it, yes.
And the people's right to have it. So.
And it's in hospice, there are the outliers who aren't on hospice. Most are. And in hospice, it is mandated that every decision is made by the interdisciplinary team. Mm-hmm. So that includes the patient, the family, the nurse, doctor, and in this case it would be another provider. So what did I say? Social work, chaplain, volunteer. I mean, the entire team needs to be involved. So specialties and all, and people who believe or don't believe, but nobody must participate in that decision. Mm-hmm. No one is required.
Yeah, but none of those other people's voices make a difference regarding if they're going to choose it. So like the nurse, somebody on the team said, absolutely. I don't think they should, as long as they have the prescriber that's willing to do it. Yeah,
it's not anyone's choice to say someone should or shouldn't.
And why should it be a doctor? Why should it be a medical provider?
A medical provider doesn't say anyone should do it.
Or why
they say you have a right to do it.
Why should they be the gatekeeper?
And by the way, only a third of people don't use, only a third of people use medical aid in dying when it's prescribed. So a lot of times it's really a comfort, and people don't use it at all.
Well, this brings up an interesting thing is we don't know in New Mexico. We don't know in New Mexico. It's the law that it's reported, but then there have been no reports since 2021.
Well, yes, but
that's why I was asking that question.
This is not the fault of the law or the people. So we use what Miles is referring to is in the law there is a reporting requirement, and the Department of Health, and we do report, and those forms are available through end-of-life options, and those forms have to be reported to the Department of Health, but unfortunately, and they have to be publicized. However, for the 5 years, there hasn't been one report. That's not the fault of the law. That's not.
Right.
So
right.
we rely
but we don't know
on.
How many.
There are also 13 other states besides us, if you include D.C., the District of Columbia, that have the aid in dying or death with dignity law, and so we rely on those figures. Not all of them have the same reporting requirements,
right. But we don't know what the numbers are here.
That.
You use the 1/3, but we don't know it. At least in New Mexico, we don't know.
No, that's a national number. Mm-hmm. That's combined.
Okay.
So
thanks for clarifying.
Yeah.
So why should a doctor, and specifically a hospice doctor who supports medical aid in dying, why should all of the weight be on them to either pass or fail the person that's asking for medical aid in dying?
They never fail. They have to refer to another hospice.
Right. No, I'm saying the person that does support it. Why is a doctor who is an expert in end of life, mm-hmm. And supports medical aid in dying, why do they get to be the gatekeeper for these decisions?
Because they are, and according to the law, supporting patient autonomy. They aren't supporting medical aid in dying. Nobody's a supporter of aid in dying or a non-supporter. We're a supporter of autonomy in the right to make that decision. And so maybe I'm an oncologist and I don't support radiation for whatever, only chemotherapy. But there's, it's indicated. But I just personally don't like it. I don't just say I don't like radiation. I say let me refer you to, if you want to be consulted. So
we're talking about, again, treatment, care, but in this case we're talking about a prescription, which I consider an overdose, and I think we'll have to save that for another conversation, because this one was probably going to be long enough. But it's a lot different to refer to somebody who's already favorable towards the thing that they want, and then
toward following the law and having the right.
Right. And determining if they are allowed to make that autonomous decision, which, like you said, that's pretty much going to be
it's the
pretty
two
clear
providers
path.
and an interdisciplinary team, and the mental health provider as well if need be.
If needed, but otherwise, no one else's voice can do anything except the provider that is already in favor of it.
That's true. I mean, we trust, and we've seen, we're almost 30 years in Oregon now, and we have seen there are really no instances known about people who don't act ethically, who just like want to prescribe to everybody because they think it will make them happy or something. That's just absolutely, that's just not the case. And that brings me also next time, we'll do another one and we'll talk about the overdose, and we'll also talk about the slippery slope argument that I know you propose, and I...
Not as much with the slippery slope. I mean, there are some...
Or the disabilities, so we'll touch upon those. Be unique.
With this, the option of that doctor to support this person's autonomy to the end, to ending their life, why... That's not a doctor's job. Nowhere else in their profession are they just saying, I'm going to support their autonomy regardless of anything else except only prioritizing that one issue. Why is it that in all other healthcare, in all other medical practice, there's assessment?
Right, I mean, there is assessment. Maybe. There has to be.
Depending on the provider, how deep and how rich and the education.
First of all, we know how old they are. We know that if they're on hospice that they have a 6-month prognosis. And if it's a non-hospice provider, they still have to follow those Medicare criteria for a 6-month prognosis. And those are established with actuarial statistics. So
what I'm saying is this is the only time that a provider's main impetus is supporting autonomy. Why is it so different, and why aren't we asking providers to do what they normally do?
Oh, I don't think it's different at all. When it comes to dying in our country, we do allow people to choose not to be on a ventilator. We do allow people, if people want to stop eating and drinking, we allow people to overdose. I don't consider this an overdose because it's the prescribed dose with the prescribed outcome, but people can do that anyway. Everybody has the right to do that.
Right. So why give that power now to a doctor that's already in favor of it?
In favor of the person's decision. We're only giving the prescription. We're not giving it to the individual.
Right.
Then the individual has to self-ingest, understand.
But there's a lot of people at all points of life who have a lot of autonomous desires. Not all of them are good for them. Not all of them are good for society. We do know that in states where assisted suicide is legal, medical aid in dying is legal, that the rate for other suicides is also higher.
So
what I'm saying is the impact of somebody choosing to end their life and supporting autonomy to the end and asking doctors to support autonomy to the end, it impacts not just the person making the decision, it impacts the whole society.
Staying alive and suffering impacts the whole society.
A lot of times in a beautiful and glorious way, because we have amazing stories of people that endured these things.
But you need to understand that not every death is a good death, and that we get to make those decisions. And I get to make a decision if all I ingest is Coca-Cola and Hershey bars, and I smoke 2 packs of cigarettes a day.
But that's not a doctor. That's not a doctor making that choice for you. This is a doctor writing a prescription.
But they are not making the choice. This
is
where we really disagree, and
that's why it's getting a little.
This is where I don't know that we can talk factually. I mean, I think I'm factual, and you think that yours is factual, but
this is where
we'll never get past this where I absolutely understand and believe and know that the doctor isn't making the decision for someone else. I absolutely know that. But they're making sure it's safe.
Yeah, we also know they are absolutely prescribing the medications that's going to end their patient's life.
That's true. And they can go elsewhere and get them, whatever. They can shop around until they find somebody to support it. Sure. Yeah, I'm going to shop around. You know, my husband's been to several people with his Parkinson's disease because he doesn't do well with Cinemat. And he's ended up at our VA and is being well cared for. And he has absolutely the right to find a doctor that will work with him on something that his body tolerates.
Yeah, that is, again, a different scenario than somebody shopping around for somebody who's willing to write this prescription to end their life.
Yeah, I don't see it as different.
One, with your husband, he's realizing, okay, this person isn't providing the medication, the
For my
equipment,
quality of
the
life.
DME, for quality of life, we can say
So
that.
that I don't vomit and have diarrhea
Exactly.
every day.
Right, so they're wanting the comfort, the care that they need.
That's exactly what it is to look for a prescriber for Adidine. So it might be a good, well, you could get the last word, and this might be a good place to end.
Yeah. The difference is that's for continuing life, and the intention is improving life, not intending to end life.
That I still consider it the same. So I love you, and I love that we agree to disagree. And I think there's plenty of material.
I know.
We will
we'll keep this
go
going.
on and we'll do part 2. And if it seems like there's more discussion without rehashing what we've already rehashed.
Yeah, we'll try not to do any
Hash and rehash.
rehashing. We might revisit some things.
So, you know, we'll continue this discussion and until that happens, that we feel like we're repeating information. So I hope this has been helpful for others, at least helpful to just have the conversation.
It is.
Yes.
It's good for people to know what the law is in the state that we live in, and we can maybe look at some of the other laws and things down the line of other places and changes or updates and so much.
Absolutely.
And this is just the tip of the iceberg in a way.
It is.
So I'm looking
It
forward
is.
to further conversations
Thank
with
you, Miles.
Yeah, of
I
course.
appreciate you
Yeah.
so much.
Definitely. Yeah. All right,
All
so
right,
stay
thank
tuned, everyone.
you.
We'll stop this recording and stay tuned for the next time.